Hey everyone, this is Soph, and you're listening to the Beyond Pain and Fatigue podcast, where together we'll explore the complexity of chronic pain, fatigue, and invisible illnesses. Hi everyone, thanks for joining us. Today we're diving into a condition that is still widely misunderstood and often missed and profoundly impacts the people who are living with it, postural orthostatic tachycardia syndrome, or POTS. I'm incredibly grateful to be joined today by someone who brings not just a clinical and research expertise, but also her lived experience. Someone who has dedicated an immense amount of energy and time into improving outcomes for people living with POTS, Dr Marie-Claire Seeley. Claire is a senior research fellow at the University of Adelaide, a clinical nurse, and a Churchill fellow with over 30 years of experience living with postural orthostatic tachycardia syndrome. In 2021, she founded the Australian POTS Foundation and now serves as CEO, leading national efforts in advocacy, research, and healthcare reform. In 2025, she received the South Australian Science Excellence and Innovation Award for her pioneering work in autonomic disorders. Her research is driven by her lived experience and focused on improving outcomes for those living with POTS. I'll also take this opportunity to mention that Claire has recently co-authored a state-of-the-art review on POTS, which was published just last week, so very timely. It's, from my perspective, an exceptionally clear and really useful paper, and it's one I'd really strongly recommend to any clinician who wants a really comprehensive, up-to-date overview on pathophysiology, assessment, or management of POTS. So massive congratulations to you and to the authorship team, Claire, and thank you so much for joining us.
Thank you, Soph. That was a wild introduction, and yeah, we're super excited about that paper. It was an invited review, but it's taken some time to get up, and as you mentioned, it's quite extensive, and it has some of the world-leading clinicians. In fact, the majority of the world-leading clinicians and researchers are on this paper, and we were so thankful that they were willing to give their time and energy to help us put this out so we have an Australian context for POTS and how to manage it.
Absolutely. And I think that's one of the things that stands out to me as a clinician researcher myself. I think quite often there isn't always a whole heap of research actually being done in some of these spaces. And, I think POTS in particular, there really isn't a whole heap of people that really come to mind when we compare it to other diseases, other conditions. There's not really a whole heap of people who are kind of researching in this space. There's a lot of clinicians and a growing number of educators, but it is a space that's really, in need. So fantastic contribution. I can only imagine how much time went into it. So I guess to start, Claire, you've obviously got a very impressive resume behind you. You've done a lot over the years, but I'm interested if you could maybe just in your own words, share a little bit more about yourself. And I guess, tell me more.
I actually haven't done heaps over the years, to be really honest. I've done a lot in the last 5 years actually. And to my shame, certainly in this space, I really didn't engage in this space for most of my life, even though I was affected by POTS back in 1993, which incidentally is the year that the name postural orthostatic tachycardia syndrome was first attached to this long-known orthostatic disorder. So POTS is not new. It was described in medical literature back in the 80s, in fact, and it's been called a whole range of things. And since 1993, known as POTS, and that was named by Mayo. So for want of a background, I'm a clinical nurse, but I didn't even come to my nursing early. A country girl from West Australia. I was a little impatient. I couldn't be bothered with uni, even though I was very clever. I just wanted to travel, which I did. And at the age of 21, I went off overseas, and that's where I met my husband. And that's where I got POTS after a virus. Then we went on to have 4 children. So I have 4 beautiful grown children. They all have partners, and we've got 4 grandchildren. So we have a busy family life as well. And I really always wanted to do something medical. I had a real fascination, and particularly after I got POTS and I was treated appallingly, really. I'd never come across that before. I had no real need for doctors growing up, and I wasn't aware of that kind of gender bias that we talk about so commonly now, but it was really startling to me to be, presenting to someone so unwell with such dramatic symptoms. I had extremely high heart rates. I'd been a very, generally very fit person, or certainly very athletic. And, I hadn't had a long time of bed rest or anything that would explain why I suddenly had this huge heart rate after contracting a virus. But of course, like everyone else who's been through this journey, was essentially told this is in your head, you're anxious, you just need to deal with your anxiety. And I certainly wasn't anxious, and I'm fortunate that I've never really suffered from anxiety, just normal day-to-day stuff that other people might. Occasionally when the plane's bumping, I might get a bit of anxiety, but I knew that wasn't the answer, and my husband knew that wasn't the answer, but we had nowhere to go then because there was no internet. We couldn't research. As the internet did eventuate, I got more and more interested in kind of doing my own Google searching, back when you used to have to dial into the internet. And I started to discover that I did, have this condition that was being talked about, this orthostatic intolerance or tachycardia, fast heart rate when you stand. But then I did actually pursue my nursing. When my fourth child was born, I went back to university, became a nurse, and then very quickly went on to do my critical care postgraduate, became an emergency nurse, and eventually worked for some time at Monash Hospital in Victoria, and then got into education as well. So I was both a dual academic and emergency nurse. Again, still just researching in the background about this condition, POTS. And that's really, it wasn't until my own daughter got a virus at 14 and presented with exactly the same symptoms that I started to think, this is a familial problem and nobody's doing anything about it. Again, I left it for a little while, and it really wasn't until 2018, so just pre the pandemic, I had a sudden flare in my condition, which was dramatic, out of the blue, no apparent trigger. Trail running, doing lots of walks. My husband thinks I was over exercising. I don't think I was, but I did do a 30K walk, after which I never really recovered, and I had lots of symptoms at that time, and then the POTS just went out of control. I couldn't make it from my bed to my bathroom without crawling on my hands and knees. And through that process, in the next 6 months of being really unwell, I came across a few fantastic clinicians, and one of them actually was Professor Dennis Lau. And he, for your listeners, if they don't know, he had an interest in this space already. He was publishing back in around about 2015 and 16 with Rachel Wells, who was doing her PhD in POTS. They published a whole stream of papers back then. And he hadn't been educated about it at all. He had just been sympathetic to his patients and believed them. And anyone in this space knows that if you believe one of these patients, you're going to get a whole lot more, because word gets around. And Dennis just one day said to me, you really need to do something. You know so much about this, and we need researchers. We need people educating doctors in this space. And that's where it all started. So it was 2018 or probably 2019, 20 that I really took up the mantle.
I mean, I appreciate, I guess, your humility and sort of being very quick to say, well, actually, I came late to this. But I think, I mean, to me, when looking at everything you have been able to achieve in the last 5 years, I would say, arguably that makes things even more impressive. Like, I think it is such a huge amount of forward momentum, and you've contributed so much and really helped, in my opinion, really helped move things forward for people living with POTS in Australia. And I don't think I can overstate that to our listeners here who might, not have come across you before, but it really is quite amazing. And I think a really fantastic example of, I guess, coming from your own lived experience. And it sounds like really that having that be the driving force to actually go, you know what, I want and need to do something about this. And I think even as a clinician, I speak to a lot of clinicians who are all very passionate people. They really care about their patients. We want to do better. But, I guess there's very few people who then take that step to then looking at it on a bigger scale and then going, how can I kind of shift things beyond just my clinical encounters? How, what can we do to help move things forward? And, that's I guess a rare quality and takes a hell of a lot of dedication and time and energy. I'm interested, I guess, how did the POTS Foundation come about, and what does your role there kind of look like?
Yeah. So speaking of ADHD, Dennis has a lot of ideas. At the time that I came on to do my PhD, I had a lot too. And when I first talked to him, I said that there are a million things here because nothing much has been done in this space. So what do we look at first? Do we look at epidemiology? Do we look at, the biological factors behind this? Do we look at experience? And I had some qualitative and quantitative background research experience, and I could have gone both ways. And Dennis was actually the first one who really said we need a registry, a patient registry. And I'm like, well, that's beyond a PhD. A patient registry is a huge thing to set up, but he doesn't see many barriers to doing anything. And I was convinced that after a while that maybe that was the thing for us to do. And at the same time, he said, so we had a lot of discussions at that time with some international groups that have really led the way and done amazing things for POTS in the US. But a lot of their stuff is very contextualized to America, of course. And one of the issues was that there was no cohesive on the ground group here in Australia. There were disparate clinicians all around the country who maybe understood this condition, but had no support themselves and no way of connecting with other clinicians who understood this space. So there was this missing platform by which both clinicians could get together and understand and learn more, but also the community. I mean, this condition was affecting probably hundreds of thousands of people, but in isolation. And some of those people had got together on Facebook forums, and we've all been there. And they are helpful. They have a place for people who are searching for answers, but they can also not be fantastic places, and what tends to happen is that people go in there when they're first experiencing POTS, they get to know some things, people give them advice, and then after a while they drift away from those forums, understandably, because they're often places where people are displaying and talking a lot about their hardship, and it becomes a place that's a bit difficult for us to be. So I knew that, Dennis was right. We needed a platform for this. I have had some experience in starting community groups. I've always been one of those people that, as presidents of sport clubs, I started a netball club in Victoria. So I knew how to set up governance. I knew how to do these things, but I was like, is this a wise thing? I've just come out of probably one of the worst health periods of my life. I had just had my son graduate from school, so I was finally kind of free with all adult children. The pandemic had just hit by this stage, and everyone was sitting at home kind of watching nightly news, the updates on COVID, and making sourdough and thinking, what should I do with my life? And I guess I was one of those people. I also, at the same time, by this time I'd started working clinically with Dennis, started to see these people coming through the door with new onset POTS. At first, it was actually from the vaccine. They were the first people that we saw. And then as COVID hit, just a swathe of new POTS patients, doctors, lawyers, nurses, or particularly health professionals who were hit first. And we knew what it was and no one else did. And everyone's like, what's this long COVID? And it was a real catalyst for me to go, yeah, no, we need to get the word out. So we formed the Australian POTS Foundation as a completely separate thing to the work that Dennis and I were doing. I went and formed the foundation on my own. I knew it was important to keep it independent from the research and the clinical side. And we got some great community people on board who had no idea about POTS. But I knew these people. I knew they had legal governance experience. I knew that they were great people to work with. So we formed a board. And I just thought, I'll just do this on the side. It'll just be, a little side thing that I do. We got a website up and going, and really it just snowballed. And the more I did, the more need there was. And within this 5-year period, Foundation has done amazing things. We have no full-time staff, well, no staff at all. We have a couple of people that do a bit of contract work for us for our marketing. But essentially everything is done out of volunteer time between mostly Dr Seeley Gallagher, who's our scientific chair, and myself. And then also we have a fabulous volunteer/social media contract person called Claire Clark, who had developed POTS around that time and was unable to work anymore as a paramedic, and really was kind of homebound. She was very severely affected. And between the three of us, we've really kind of pushed this forward with the board's supervision. Strangely, back in 2022, I realized one of the biggest issues was there's no ICD coding for this condition. Listeners, the International Classification of Disease Code is really important. All around the world, people use codes for diseases when patients go in and out of both public and sometimes private hospitals. And what it means is that the government can track what that disease burden is. If a disease doesn't have an ICD code, it gets coded to something else. So POTS was being coded to either other cardiac arrhythmias or other autonomic disorders, mostly the cardiac arrhythmias. So all these presentations to hospital we knew were being coded as something else, and it was invisible to the government. So we were trying to talk to the government. They're like, we've never heard of it. There's no data on it. You don't know how many people have it. You don't know how much it's costing us. So one day I got a bit bored and just went on and had a look like, how do we get an ICD code? And lo and behold, anybody can nominate one. So I just nominated it, right? I just wrote out a kind of a 5-page document, put it in, and it took a while, but that got accepted back in 2023, at the end of 2023. It didn't come in until 2025, but that is a massive gain. And through that and everything that we did with the government, I think we really have achieved an enormous amount of awareness around POTS. Still no changes in health policy, but awareness is there.
Well, absolutely. And I think, that ICD code is really huge. I think, like you said, so much of our funding and our priorities, health priorities, revolve around what we can see in terms of data, how much a health condition's costing us and how are they affecting people and what flow-on effects is it having to people's ability to work and all these sorts of things. But unless you've got a really clear way of actually identifying that burden, which you need the codes for, it's really hard to do that. And so I think the flow-on effects of being able to get that ICD code up and running in Australia is immense. I don't think, we probably won't see the full impact of that for many years, but I think it's such steps, huge moves forward in, a fairly short space of time, and one that I think is really important. You've obviously got your own lived experience, and we're both, I guess, clinically work a lot with these conditions, but I'm really conscious that, we may have listeners who may not actually be that familiar with POTS. So I guess if you were sort of explaining POTS to someone who hasn't come across it before, how would you explain what POTS actually is?
Yeah, so POTS really is a description of a symptom in terms of the name postural orthostatic tachycardia syndrome. So postural just meaning, when you're upright. Orthostatic actually means staying still upright. And tachycardia is the fast heart rate. The syndrome is the bit that gets tacked on to say it's not just that, it's a lot of other things. But what is POTS really? POTS is really a nervous system disorder. And if you're not familiar, we have a nervous system that is divided technically and traditionally, although the argument now is that it shouldn't be, that it's all one nervous system. But we often talk about this peripheral nervous system and the autonomic nervous system, which is the part of the nervous system with all the small nerve fibers that control all the minute unconscious functions that your body carries out from second to second. So we live in a world within a lot of environmental change. When you think about it, our bodies have to deal with gravity every time we stand up. We've got a lot of fluid in our body, and that fluid will fall due to gravity. So how does it get back up to our heart and our head? Given that we don't have a pump in the bottom of our feet, it does that through autonomic nervous system control. So squeezing of vessels, increasing of heart rate to pump back around. It also controls our sweat function so that when we're hot, we sweat, we cool down. It controls our internal thermoregulation. It controls our endocrine system, which controls all our hormones. So that is right through from blood volume, hormones that maintain our blood volume at the right level, but also probably some of our sexual hormones and the release of those. It even releases all the little enzymes into your gut that digest all your food, and it moves your gut. So the bowel moves and your esophagus moves all the way from the top to the bottom in coordinated waves, and it does that through our autonomic nervous system control. POTS is when that autonomic nervous system has been disrupted. and it is out of balance. And so often with the nervous system, we talk about fight flight response and a rest and digest, or in the technical terms, parasympathetic and sympathetic. Sympathetic is that fight flight response, that's you getting a fright in the middle of the night, your heart starting to race, your body's getting ready to run and fight because it's been frightened. And rest and digest is actually, some of your listeners will be familiar with. They get unwell, they feel nauseous, and, they'll get what we often refer to as a vagal kind of feeling. And that's more your rest and digest feeling. And apparently, we have this concept that they're supposed to be the yin and yang. We're supposed to have this nice balance between sympathetic and parasympathetic. It's far more complicated than that. We don't actually have a balance point, but we do have this constant fight and coordinated kind of, sometimes they're running at the same time. And if one's more dominant than the other, then you get these problems. So imagine if your gut wasn't moving the way it should. Imagine what happens if your vessels don't constrict when you stand up and your blood doesn't return back to your heart and your head. All the symptoms that we see in POTS can really be taken back to that dysfunction of the autonomic nervous system. The dizziness when people stand up, the loss of vision, sometimes the roaring in the ears, the sweating, the tremoring, that's all sympathetic nervous system issues when your blood does not return to the brain. Your brain can't do without that blood, so you often also get these associated brain fog issues where people just feel like they can't think. They may have difficulty with their memory. They may have ADHD type issues, and that's because they're not getting good blood flow back to their brain like they should. So POTS really is, we think, and we don't know because we don't have all the data in yet, but it looks like it is an autonomic nervous system disorder. What is causing that is probably a multitude of things, and it's probably different for a lot of different POTS patients. So some people that come in, it's because their blood volume is not being regulated the way it should be and they need more blood volume. For other people, it's the small nerve fibers are not functioning properly and they're not constricting those vessels. And this is what makes POTS really difficult, number one, to research, and number two, to treat. If you don't have people suffering from exactly the same cause of a disease state, then it's very hard to research them because you're going to get different outcomes for every participant in a research study. And it's the same when you're treating people with POTS. If you treat every person with POTS the same way, you're not going to get the same outcome because the root cause of what's causing that autonomic disruption is quite different in different people. And so often this actually takes a personalized medicine approach. It takes trial and error. We know the things that kind of work for most people, but some things might work really well for one person and terribly for another. And this is where it gets quite difficult then to educate and treat personalized medicine to a large workforce of doctors and allied health clinicians. And it's an art, and it takes a long time to develop that art.
Absolutely. I think from my own experiences and from talking to other clinicians working in this space as well, there's this kind of inherent level of uncertainty when we're working with people in this space, that we're not going to just have one clear protocol or checklist of things to do and, we'll do this, this, and this, and people are going to get better. We kind of need to be coming at it being well informed and having an awareness and understanding of all of this complexity, but also kind of accepting that we're not necessarily going to have all the clear answers. And a huge part of it is kind of learning to work within that uncertainty and kind of, I don't know, almost a bit of trial and error and really collaboratively working with people to kind of work out what works for them and what's going to be most helpful for them in their context. And I think that generally is a bit of a hurdle, even outside of POTS. I think a lot of health conditions we kind of would benefit from that sort of approach, but it's not always the way we're taught to think as health professionals either. I think back to my own training, we were physio background, we were always taught to be very methodical. We're assessing these biomechanics and this muscle strength and this joint range of motion. And if we assess these things, we can follow that sort of that flow chart of what to do, and then people will get better. And I don't know, it seems like when we then start branching into things like, pain, fatigue and conditions like POTS, that kind of falls down. And as clinicians, we kind of need to kind of shift our thinking as to how we even approach these things, I think.
Absolutely. And I think this is a really key point to make around this. And this is one of the difficulties in working with health policy, is trying to get across to government what our issue is. We come from a very Western medicine biomedical model that is very siloed health. I am very for Western medicine. We have changed the world, and we only have to look back to my grandmother's era to know how many children died before the age of 5. And all the changes has been because of modern medicine and our understanding of acute illness. Fortunately, what that doesn't really cater for is the chronic illness components. Everything in our health system is set up to stop you from dying today at this moment. So if you're really unwell, you go to an emergency department, they stop you from dying. What they can't do is easily figure out when you're chronically unwell. And that's because chronic illnesses, which predominantly affect women, so we're talking about complex chronic illness. We have a lot of chronic illnesses in our community that are from heart failure and diabetes, which kind of affect everybody. But when we're talking about chronic complex illnesses, we're often talking about these really subtle inflammatory type conditions that are female predominant. And they're things like autoimmune diseases, so Sjogren's, which is a small nerve fiber disease, which is actually really common but poorly diagnosed in Australia. Come to our conference in June, you'll learn a bit more about Sjogren's. Endometriosis is an example, and thyroid diseases, POTS, ME/CFS, long COVID, connective tissue disorders. These are all diseases that do predominantly affect women. They definitely affect men, but they don't kill people generally, and they don't kill them quickly. So people live with these conditions in a chronic state of both pain and an unwellness. And there's nothing for the modern medical establishment to quickly do to rectify this. So emergency departments are not the place for people with these conditions, but nor is there anywhere else for them at the moment, because our system is set up in a very siloed system. And this is why people start seeking alternative health solutions, some of which are fantastic, some of which are terrible. But that's the space in which they often get a listening ear. And a lot of this is about clinicians listening and helping to, for want of a better word, health coach these people into managing their own condition. And so this is, where POTS is quite difficult to go to the government and say, what do we need? What we need actually is a lot of multidisciplinary community care. And people going through education to understand what this condition is and how to adapt and adjust these personalised medical plans for each individual patient that comes into their clinic.
You touched on really nicely, I guess, the complexity of how people with POTS might present in terms of lots of different systemic symptoms. There's a whole host of things that people might experience when they come in with POTS. And hearing you talk about that sort of complexity and all the things that the nervous system is involved in, it also makes me think about, I guess, the added layer of complexity we see where we're talking not just about POTS itself, but also how it kind of overlaps. And we often see these overlapping complex chronic illnesses that show up. I know there's been a lot of discussion lately around some of the cross sections with things like hypermobility disorders and Ehlers-Danlos syndromes, and as well as things like chronic fatigue syndrome, long COVID. There's been a lot of kind of discussion in this space. And I think a lot of clinicians who are working in that space have been exposed to that and sort of know that sort of clinical complexity and how people are presenting. But it seems like we're still very much in the exploratory phase of trying to work out exactly what's happening there in terms of these overlaps.
I would say that, if I had to lay my money on something, what I would lay it on is that this is a genetic connective tissue disorder for all of those things that we've just talked about. For endometriosis, for POTS, for ME/CFS, for long COVID. The root of this does lie in this phenotype, so this presentation of people, for want of a better word, hypermobility, but I don't like that because there's a lot of non-hypermobile people with this phenotype also. But we do know that hypermobility in the young is a marker of people that have this underlying connective tissue disorder that isn't well described. So we still have no gene for this hypermobile Ehlers-Danlos syndrome. We have some positive points towards genes, but they're not established. But as a clinician, you're left in no doubt, right? You see these people daily. They all have a similar, there's kind of two types of phenotypes. You get this Marfan-y looking person, and for those who don't know Marfans, it's the long gangly limbs, the long fingers, and these are people, we used to kind of refer to rubber men when we were younger. They are those people that are quite rangy and maybe sometimes even uncoordinated. And then you also get the opposite of that, people with these kind of smaller hands, rounder faces, and very, what I call, doughy skin. You feel like you could put your fingers into their skin and it's doughy. Your connective tissue makes up everything. It makes up your vessels. It connects every muscle in your body. It connects, your brain, your nervous system. It's the interface of everything. It's the interface of all your nervous system interactions. So if the connective tissue is not quite right, is a bit hyperextensible, a bit thin, you're going to get a plethora of issues. And for some reason, these people are also our autoimmune kind of genetic pool of people. And it's the autoimmune component of it that I suspect leads to POTS, but also leads to Sjogren's, lupus, all these other conditions. I think anyone out there who's starting to explore this space will recognize that they come from a family, if they've got these conditions, they come from a family where there's probably a history of things like, yes, we were all orthostatically intolerant, that being in the summer, if we stood up after we'd been sunbaking, as we used to do in my day, we probably couldn't see, we'd lose our sight. We might feel like we're going to faint. We just had to put our head down between our heads between our knees for a while, and then we'll be fine, right? It wasn't dramatic. It's just what happened to every person in your family, and particularly the females. Or, mum had extremely heavy periods. So did my sister. So did I. That's normal. We all had ovarian cysts. That's normal. We all had endometriosis. That's all normal. And this is all because this really is a genetic kind of component in here. But there is a point at which those people also become predisposed to an environmental trigger. And this is what happens in POTS. They get exposed to something, usually more often than not, it's a virus. Prior to COVID, Epstein-Barr virus seemed to be the virus that caused that. So that's glandular fever. Now, whether that's because we don't go testing viruses all the time, we do it more now since COVID, but we never used to. If you used to go to your doctor for your sniffle, your cold, your flu type symptoms, they rarely did a viral test on you, because unless you're really unwell, they weren't, there was no point in doing it. But now we have a lot more data. And Epstein-Barr virus is probably one of those viruses that got tested for, because people can become quite unwell with glandular fever. But we think it can be any virus. And when that virus comes, these people get this, what I used to call super POTS. So they're probably orthostatically intolerant. If we'd tested them, they might have met the criteria for POTS. But they lived life fine. They were functional. They were okay. It's this kind of interaction of this environmental trigger that unbalances everything. They tend to get what we often refer to as mast cell responses, at least a non-typical allergic type response. They'll start to develop rashes, intolerances to foods. That all drives this inflammatory response that they have, new onset allergies. And then they are in this chronic state of health, of being unbelievably fatigued, orthostatically intolerant to the point that they can't continue school, work, education. So it's not just the few seconds when they stand up on a hot day, it's all the time. And often they start to experience severe pain. And I am sure, and one day we're going to find out, what is that particular thing? Is it an antibody? Is it a whole inflammatory cascade, which I suspect it might be, which is why it's difficult for us to find the root cause. But it's people at that point that really need help. When you get POTS from an environmental trigger like that, over 50% of those people don't return to work again. I mean, that's a staggering statistic for young, mostly healthy women prior to that event. And if we get this data and show it to the government, I don't know how people can't be absolutely alarmed by that after a pandemic where 80% of Australians have experienced a COVID infection, and somewhere between kind of 3 and 10% of those are going to be lifelong affected with POTS.
I think it is something that it often does go unrecognized, I think. I still meet clinicians who've kind of never heard of POTS when we've been speaking about the work that I do, and I'll mention POTS and they'll be like, oh, I've never heard of that. And it's always interesting to me because the thought that I have is you might not have heard of it, but I can almost guarantee that you're seeing people or you've seen
100%.
people who are through. You touched on before that, there can be a lot of challenges when it comes to actually seeking care, and the awareness is certainly one. I guess if we were to talk a little bit more about some of the clinical aspects of this. So if somebody is suspicious that they have POTS or they're being evaluated for some of these symptoms, how is POTS usually diagnosed? What does that look like in clinical practice?
Yeah, so the good thing about POTS in comparison to many of these other chronic conditions is that it does have a defined diagnostic criteria. Whether it's exactly what we want, I don't know. We can have a long argument about that another day. But POTS was defined back in, as I said, 1993, when a group of autonomic clinicians, so we don't have this specialty in Australia, but there is a whole specialty in America called autonomic neuroscience, and you can be specialized in that area. And they decided to look at all these orthostatically intolerant young women that came into their departments. They would do what they call a tilt table, where they'd lay them on a bed, strap them on that bed, put a lot of monitors on them, and then slowly, well, quite quickly really, tilt them up and look at how their autonomic nervous system controlled their blood pressure and their heart rate in that moment. And they were able, because they had controls, so people without that condition who had done tilts as well, they were able to compare these people with this funny symptom set with people who are otherwise well. And then they were able to establish what is normal and what is abnormal in terms of what happens on tilt. And what they found was that in these people who are unwell, what was abnormal was this really high heart rate without a blood pressure drop. And for the clinicians amongst us, you will know that normally a heart rate response that goes high is due to a blood pressure dropping. So that's usually orthostatic hypotension. But these weird people had high heart rate, but their blood pressure stayed the same or went higher, which seemed unusual, but is a sign that the autonomic nervous system is throwing out a lot of adrenaline. So the vessels, particularly central vessels, are really trying to constrict, and the blood pressure stays there, but they've got all these other symptoms as well. So POTS was defined by that. What they found was that a 30-beat rise in heart rate from when you're laying to when you're standing is abnormal. And I would just put a warning out there of caution. Unfortunately, that study was done comparing a group of controls who were equally female and male, so they had 50% male, females basically. But the sick group were mostly females. Now, interestingly, men have a lot higher heart rates on tilt. So men generally are very sympathetically updriven, and that's because of their fight-flight response is essentially innate in them as part of the hunter-gatherer kind of thing. So men do have higher heart rates, and the men in that control group did have a lot higher heart rates on tilt table. So the diagnostic criteria did not take into account sexual differences in terms of biomedical sexual differences. And so they just set a standard criteria, whereas if we were doing that today, we would have set what is an abnormal heart rate for women and what is an abnormal heart rate for men. For women, the abnormal heart rate would be a bit lower than the men. I think, we as clinicians, we should keep that in mind, that really a heart rate of around 27 on a tilt is probably more likely the threshold for women. What else they put into the criteria was that this person must have no other explanation for that tachycardia. Now, lots of things can cause tachycardia. If you're dehydrated, obviously you'll be tachycardic. If you're malnourished, you'll be tachycardic. If you have a thyroid condition, you might be tachycardic. It still is abnormal with all of those conditions to get a change in heart rate from laying to standing. If you've got a thyroid disorder, your heart rate tends to be high universally. It doesn't explain what we call the delta heart rate, the change from laying to standing. And that's true with malnutrition too, usually. And also with both malnutrition and dehydration, you would see orthostatic hypotension. So I would still argue that, if you see a patient who is slightly dehydrated or malnourished or lightweight, and you put them on a tilt, you shouldn't see a delta heart rate change if the blood pressure remains the same. What you might see is orthostatic hypotension in malnourished people. So we do tend to say, okay, let's make sure we rule out all those other conditions, make sure they're not anemic, all the rest of it, fix them to the best of your ability as a clinician, and retest. And then the other thing is that it needs to be chronic. So any person who gets an acute illness, if you get COVID tomorrow and we put you on a tilt table, you're going to meet the criteria for POTS, because one of the first things that happens to your body fighting an acute infection is that you do get inflammation, which also causes disruption of the autonomic nervous system control. And I think almost everybody can remember a point in their life when they've had a flu, where they've got out of bed, they've felt very dizzy, their heart's racing, and they know they're not well, so they go back to bed. That's how POTS patients feel every day. But if you're feeling like that because you've got a flu, we can't diagnose you with POTS. And therefore, somebody who's been very unwell in hospital, for instance, we would say you can't diagnose them with POTS until they've been unwell for 3 months and, they've had that acute illness pass. So the diagnostic criteria for POTS is either on tilt table or just doing a standing test in a clinic where you lay flat for 5 minutes and then you stand still for 10 minutes, and we take your blood pressure and heart rate every minute. And we're looking for that delta heart rate rise that is sustained without orthostatic hypotension, no other cause for this condition, and that it's been chronic, at least 3 months at that time.
I think the remarkable thing is for what is a very complex condition, I've always been kind of impressed at how clear the guidelines and the testing is. It's so rare that we actually get such clearly defined and relatively easy to assess sort of things to use in clinic, I think. And certainly I know the POTS Foundation, if anyone's interested, I know there are some really good resources that kind of outline the testing protocols and things, for how that's actually tested.
We've actually just put up an active stand test video, so that's quite new. You may not have seen that. So if you want to go have a look at that, how to carry that out in your clinic, it's a really simple video just to give you instruction on that.
Absolutely. And I know that it's often been, from my experience, quite difficult sometimes to find specialists, often in discussion with other health professionals, it's sort of a question of who do we need to refer people to for diagnosis. And sometimes finding specialists can be tricky. Finding specialists who are maybe aware of and insufficiently informed on POTS is trickier still. So, I mean, I've certainly seen a lot of discussions about, I guess, how do we sort of approach diagnosis and does everyone need to see a cardiologist to have a tilt table done, or, can we sort of be diagnosing this more in primary practice? Well, I guess where's the sort of current stance on that from your perspective?
Yeah, I mean, if you want to read the state of the art review, you'll see where our stance is on that. So tilt tables, unfortunately, in Australia, one of the issues with tilt tables, so the history of the tilt table is it's there to find out why people have sudden unconscious collapses. And it can discriminate some of these other autonomic conditions, one being vasovagal syncope or neurocardiogenic syncope. And they're kind of syncope or faints where people have no warning and injure themselves. So they often can break bones, dislocate jaws, things like that. And obviously we really need to figure out what is going on with people when that happens. And that's really where the tilt table came from. It was a safe test to do to find out why people are fainting. Now, in America, as I said, they have an autonomic neuroscience specialty. They have special autonomic clinics where they test both the sweat function and the tilt table and other kind of funky tests as well. And so a lot of the literature around POTS came out saying tilt table is gold standard, which, it is, because that's where the diagnostic criteria comes from. The thing is that really that came from an autonomic neuroscience spectrum that's looking at multiple other conditions. But it wasn't contextualized into Australia. In Australia, number one, we don't have an autonomic neuroscience specialty. So it's very rare to find anybody in Australia that knows how to test typically things like Valsalva maneuvers or small nerve fiber function. There are a few clinicians that have been exposed to it in America, but very few around the place. But we just adopted the oh, we have to do tilt on everybody. And the tilt went into the cardiology space. Now, in America, tilt tables are mostly for POTS. They're done by neurologists. In Australia, they're almost always done by cardiologists. And cardiologists on tilt tables use what we call provocative testing. So they will go giving injections of or sprays of medications that vasodilate patients to see their autonomic response. I can tell you, if you put a patient you put anybody actually on a tilt table and give them something that vasodilates them, they're going to faint, 9 times out of 10. It is not a test that discriminates POTS, and it's not useful to do in POTS. And in fact, I go as far to say that it's harmful, and that's because I have seen harm from it. So if a person with POTS doesn't get normal cerebral perfusion anyway when they stand up, you put them on a tilt table and that's exacerbated by tenfold because they get no muscle contraction in their legs on a tilt table. So they get no blood pressure support. You drain their brain of blood, which often will lead to not just unconsciousness, but can lead to a hypoxic seizure activity. And sometimes that hypoxic seizure activity can lead to their heart just momentarily stopping. And I have seen cases here in Adelaide of young girls at the age of 23, 24, who all of this has happened to, and then they've ended up with a pacemaker inserted, which is for life. And that pacemaker does not correct their condition. This was just an incidental finding during a tilt table that was caused by the tilt table. And they go on living with POTS and a pacemaker. So I am very strong on the tilt table should only be used if we're really unsure about the diagnosis. The other thing about the tilt table is that in Australia, it is tied to MBS funding. That means that it must be in a tertiary centre. So a hospital where there's life-saving kind of ALS or advanced life-saving kind of supports. It must be accompanied by a cardiologist for the whole test. Now, that's an unbelievably expensive thing to do. They must have an IV inserted. And that's all because when they did that MBS item, they did it thinking everybody has to have this provocative medication test. We're actually working on this with the government at the moment to provide another MBS item for non-provocative tilt table testing that can be done in the community. Because what this has done is bottlenecked all the tertiary institutions that have tilt table. In some cities in Melbourne, as far as I understand, the only tilt table is at one tertiary hospital. So that's for millions and millions of people, and that's no good. What we can do is an active stand test. And now the argument against doing an active stand test is, well, on tilt, your heart rate is exacerbated, so it goes a lot higher. When you do an active stand test, so you keep the patient still and they just stand still, they still have activated calf muscles because they're standing up. So that will mean that their blood pressure is a little bit more supported and they won't be as tachycardic. And that's true. That is 100% true. But we're all clever people. We can make the decision to go, this person's doing an active stand test, not a tilt. If their heart rate only comes to 27 or 28 beats per minute, that is actually equivalent to 30 beats on a tilt. And there's now research showing that if you do active stand tests, essentially a heart rate of 27 or more is equivalent to 30 or more on the tilt table. So all you have to do is adjust that criteria. And we're talking about expert clinicians here because POTS needs to be diagnosed by a doctor or a nurse practitioner. So I would hope anyone doing a standing test in a clinic who is a doctor or a nurse practitioner would have the capacity to judge whether this was an abnormal or normal test. In combination with symptoms, which it should be, they must be symptomatic. That is a clear diagnostic, test to use. So yes, in short, we advocate for an active stand test in the clinic. We don't advocate for tilt tables unless it's unsafe for the patient to do a stand test, either unsafe for the clinician who's helping them or the patient isn't capable of doing it, or we've done active stand tests and it's not clear and this patient is having things like syncope without any prodrome or any understanding that it's coming on, then they need a tilt.
Absolutely. Even as someone kind of working in this space, that I guess the contextual differences with how it's translated from the US to Australia, that was an aspect I had not heard about before at all. And it makes sense why that would then really cause challenges when we're talking about use of tilt table for diagnostics. And yeah, I think that bottleneck you've described is something I see a lot in practice, and something that I think from my working with patients that I've seen, it seems to be a real holdup that, just getting in to see cardiologists who are aware of these conditions can sometimes be a long wait. Where I am in Wagga, often there's a lot of travel involved, or, wait times. We don't have a tilt table test here. Closest to us is Canberra, so it really adds extra layers and barriers to effective diagnosis. And I guess the thing is, right, I think, particularly as clinicians, often we're thinking about diagnosis, and often I guess the purpose of diagnosis is not just to kind of identify that this is what it is, but also then, okay, well, we know what it is. What do we do about it? And I guess that leads me to my next question is, when we're thinking about POTS and understanding what you've already said about, look, it's really complex and people do respond differently to different treatments and it has to be so individualized. If you were to give a bit of an overview as to what treatment actually is sort of appropriate for POTS, and like what are we looking at in terms of management?
I always talk about POTS when I'm doing education with clinicians. It's a preload disorder. So in cardiology, we talk a lot about preload. So that's the ability of the body to return the blood into the heart. And essentially, POTS is a preload failure. So people often talk about in POTS, I feel breathless when I stand up. They go off and have all sorts of, respiratory testing because they feel breathless. What they actually are feeling is an empty heart, not enough blood returning to the heart. And it is about this blood flow issue. And that is the fundamental cause of the POTS symptom is lack of blood return to the heart. So everything we do in POTS management then has to first target that blood return, because that lack of blood return is not only causing tremulousness and dizziness, it's probably causing brain fog and fatigue, at least contributing to some of the brain fog and fatigue and other symptoms that this patient has. So the first thing is to really try and target this orthostatic intolerance. Now, in a lot of people with POTS, that does have a blood volume issue, and this is where clinicians who don't understand POTS get a little confused. Often they're like, well, if you're drinking okay, you're going to be hydrated, right? Because they're assuming that you have a normal autonomic nervous system. What we're always taught in emergency, if they can tolerate oral fluids, then there's no need for hydration. That's not the case with the POTS patient. And that is because their blood volume is typically about 30% lower than the average person. Now, we can't go test blood volume easily, so we can't go do that test, but we have to assume that a lot of POTS patients have a low blood volume, and that has to do with that poor renal management of hormones and the keeping of fluid in the body. One of the easiest ways to target fluid volume is to use fluid but salt. Now, if you just get your patient to drink more, they're just going to pee it out because they've got this inappropriate system that is actually diuresing. And in fact, a good question for all clinicians to ask their POTS patient is, do you have to get up and go to the toilet at night? And you'll find quite a few POTS patients that have to do that because they don't adequately concentrate their urine at nighttime. So they're peeing out more than they're drinking every day. So if you give them more fluid, they'll just pee it out. What you need to do is make sure that they have a large amount of salt with that fluid. And salt is the big enemy of, the whole of public health. But in POTS, it's a friend. And no, you're not going to kill your POTS patient unless they have some renal condition, because most POTS patients are hypermobile, have very flexible vessels. Salt doesn't kill patients. High blood pressure kills patients, and salt causes high blood pressure. But that's what we want. We want these patients to get higher blood pressure. The other really confusing thing for clinicians is that when people with POTS, when they take their blood pressure, it's often either normal or high. And that's because if they're upright, they're using a lot of adrenaline. What you want to really look at is what's their blood pressure like first thing in the morning when they wake up. And if it's low, that's what you've got to assume, that it's actually low most of the time. And the time when it's high, it's only high because of adrenaline, not because of blood volume. So they are safe to have salt generally. And by salt, we mean a lot of salt, like 2 heaped teaspoons of salt extra a day, 4,000 milligrams of salt. And it's quite hard to get that amount in their diet, and they usually need to have some kind of supplementation. There are tablets out there, there's capsules out there, but you're talking about people that already have a lot of gut disturbance. They often have motility issues. If you do give them salt capsules, they'll probably sit in their gut for some time. And we have seen cases of gastritis in young girls who are taking huge amounts of salt, but their gut's not moving, and then they get a very irritated stomach. So we don't recommend that as first line. What we recommend is hydration, drinks that are not high in preservatives, colors, things like that. And also not high in sugar, because sugar does also cause a problem for people with POTS. That's well researched. Vanderbilt has done a whole stream of studies on that. Carbohydrate loads, pure carbohydrate loads, do cause things like reactive hypoglycemia in POTS patients. And POTS patients typically get quite symptomatic after they've had large meals or a lot of carbohydrates. So try to keep the sugar load down. Does that matter? We're all told you have to have sugar in a hydration drink. Yes, you do. If you've got cholera, you need to have sugar, or dysentery, you need to have sugar in your hydration drink, because it will help rehydrate you. We're not talking about rehydrating a dehydrated person. We're talking about blood volume. The study that shows that increasing blood volume with salt works on POTS patients, they didn't use glucose, they just used salt. So pure salt works. There are some really great drinks around at the moment with the whole kind of fitness mania everywhere. You'll see some very high level hydration drinks with something like 1,000 milligrams of salt in it. So one of those a day plus lots of salt on food is a good thing. Increase fluid, increase salt. The next thing is that we know that people with POTS, a large portion of them have issues, and this is probably every single person with a connective tissue disorder. So if they're a bit hypermobile, 100% they're going to have issues with constricting their vessels. So either we don't know why this happens, either it is small nerve fiber driven and they either don't have high enough density of small nerve fibers, or at the face at which the nerve fibers interact with the vessels at the connective tissue face, we're not getting stimulation of those vessels to constrict. And so the only way of fixing that with non-pharmacological means is to put compression on. And compression has been well researched and it works, but it needs to be pretty much from ankle right up to high waist. A lot of the blood volume lost in POTS actually falls to the bottom of the pelvis. It's not even down into the limbs. It's when they stand up, the vessels are very slow to react and they just get this massive pull of blood into their pelvis. If you put compression on them, you'll actually stop a lot of that. And we know that it improves symptoms, it improves heart rate. Difficulty in Australia is the heat, and it's a major difficulty because heat will also vasodilate. So if you put compression wear on people, make them hot, you're actually counteracting the benefit of the compression. And you'll find that a lot of young people don't tolerate having it in the summer. So we have a real disadvantage in our climate. Most POTS patients are a lot better in the winter than in the summer. They may not have realized that, but if they track it in a diary, that's what they'll find. They're kind of our major kind of three things that are non-pharmacological. Most POTS patients do need a pharmacological agent, particularly if this is a new onset viral kind of incident or they've recently had a concussion. Often those things help. They have to be done every day, all day at the same time, but they don't get them quite up to the way that they need to be to get them back functioning. So usually the pharmacotherapy agents do exactly the same thing. We're looking at something to target the heart rate, to just keep it down a little bit. If we take it down too much, you're taking away their compensatory mechanism. They're going to feel worse. So we usually start with something to compress the vessels or lift the blood volume. In Australia and in the state-of-the-art review, the first drug that we mention is Midodrine. It's an old drug that's been around forever. Unfortunately, it's not on the PBS for POTS. It's on the PBS for orthostatic hypotension. And that means that you have to pay out of pocket and it's expensive. It's about $120 a packet. And it's a very fast-acting drug, so it's only in the system for 3 hours. What it does is it stimulates those nerves to compress the vessels and you get a lift in blood pressure. It's a fantastic, fantastic drug, but it needs to be taken multiple times a day. It's expensive, and that's unfortunately for a lot of people not doable. There are some other medications out there, but you have to be a little careful with them for blood volume. And then the other thing was the heart rate management. So we typically recommend ivabradine because it's selective. It doesn't cause, full systemic effects. But propranolol at small dose can work as well. So that's basically the crux. Target preload failure in your patient, lift their blood volume, and compress and support their vessels so that they get blood return.
Brilliant. And I can very highly recommend that state-of-the-art review that we've mentioned as well, because I know that there is a really great section talking about medications. If anyone's interested in looking at those medications specifically and learning a bit more that way, definitely recommend you go have a read of that. There's often a lot of discussion around the role of things like exercise, for example, in POTS. Again, I know your recent paper actually talked about this a lot and kind of gave some guidelines as to things we can be thinking about and how we can do it safely. But just briefly, what's the role of exercise in management of POTS?
Yeah, I think it's good to set the context for exercise in POTS. It's quite a controversial space amongst really the community. And again, the context comes from America. A lot of our autonomic neuroscience came out of NASA because it was when they were sending people to the moon, they were realizing they're coming back to Earth and they can't function. They can't stand, they can't, they've got a lot of these autonomic dysregulation because they've been outside of gravity. And what happens when you're outside of gravity is your body deconditions. And so a lot of what we know about autonomic dysfunction comes from this deconditioning theory. And they actually did lots of studies where they put people in beds, didn't let them move for 30 days, 60 days, unbelievable studies, and watched how these people deconditioned and what effect that had on them. And that is 100% what happens. Unfortunately, what they then did was basically translate that every person that came along with POTS is because you deconditioned. It's because you had a few days in bed while you had your virus, and all you have to do is go exercise and you'll be fine. And you will still find that mentality is prominent in some circles. I was at an autonomic conference recently where basically one person who's been harping on about this for years said that he could fix everybody if they just went and exercised. And that's just not understanding this condition. If you know anything about this condition and you know the cohort in this condition, a lot of these people are super athletic people. I mean, Katie Ledecky, the world's best ever swimmer, lives with POTS every day. She has had it for 10 years. She is not deconditioned, nor are the AFL players who we treat with POTS, our swimmers and rowers that we treat with POTS. This is not a deconditioning. Deconditioning is real, it happens, and those people need to be reconditioned. But the POTS population that we're talking about mostly get their POTS from things like viruses or concussion or surgery or sometimes pregnancy. This is an autoimmune response that is causing autonomic dysfunction. Saying that, exercise is a magic pill for a lot of people, and I'm one of those people. There have been moments in my life I cannot exercise because I'm so unwell, but exercise, when I can do it, gives me the best quality of life. And what is difficult is as you get older and you get more injuries with the connective tissue problems, I've got multiple joint problems, it's harder and harder to exercise. So exercise does, increase muscle mass, supports blood pressure. Exercise keeps inflammation down. Exercise keeps mood up. Exercise increases blood volume. So if you can exercise is a fantastic thing to do. The problem is we have some of the POTS population, not all by any stretch of the imagination, but some people that have extreme what we would call post-exertional malaise, and they tend to have more of an inflammatory component to their condition. And these people, any kind of exercise can send them into a spiral downward. That is not a reason to say that exercise is bad. I really want to put that out there, that exercise is like medication. It will work fantastically for some people and it will be terrible for the person who's allergic to it. And we have to treat it like that. We have to treat it like this is a prescription. We need to prescribe it to the patient according to that patient's individual need. And if you've got a patient in front of you with clear post-exertional malaise, that kind of lymphadenopathy that you see in ME/CFS, you know that this patient is not the patient that's going to need exercise in terms of a therapy. What they do need is functionality and movement, and a clinician who's really careful with them with pacing. But for the majority of people with POTS, yes, exercise at a sustainable pace. And this is where the state-of-the-art review is really good. Caleb Shield, who's a fantastic exercise physiologist, wrote that section for us, really looking at these kind of personal prescriptions of exercise, when to move to the next level, when not to move to next level. And the important thing is not to be rigid. You must respond to the patient in front of you and their clinical needs with exercise.
Absolutely. I feel like I could keep you hostage here all day asking you 1,001 questions. And I know that, outside of your other commitments, that you'd probably be quite happy to sit here for hours and talk about
Yeah.
this stuff. But in the interest of making sure that we, stick to time, I guess I'd just like to ask you a final question. We've covered a lot of ground today, but when thinking about what we've discussed and our listeners, maybe health professionals, maybe people living with these conditions, what would be your one key takeaway for anyone who's listened to this episode?
Wow, it's hard to answer that. If you're new to POTS, my key takeaway is that you need to practice individualized medicine here, or individualized care. So listen to the patient. Pre all our imaging in this world, all these bad new things that we have that we can see into people's bodies, pre that, doctors listened to what the patient was telling them and they believed them, and clinicians listened. And I would say, listen and believe your patient. If you've been in the POTS world for a long time and you see lots of these patients, I would just say, we have lots of resources coming out. Thank you for the work that you're doing, and make sure that you share that ability with the people behind you. We have a lot of individual clinicians around the place, but we really need lots of education going sideways here. So if you're in this world, you understand this, please take the time to make sure that when you leave that clinical space, you're leaving multiple people behind you who understand and can carry on that knowledge, so that we have an Australia where anybody with this condition can walk in and know that they're going to find a clinician who can treat them.
Fantastic. Thank you so much. And thank you so much for all of our listeners who have joined us for this episode. There's so many gems from what we've sort of discussed today that I know I'm walking away with so many new bits of information. I've really enjoyed our discussion. So another special thanks to you, Claire, for joining us and for volunteering your time to come and share your insights and expertise. I'm so grateful for you to take that time. And, it's been so valuable for me to be able to discuss these things with you. And I'm sure very valuable to our listeners as well. So big thank you to you.
And thank you for having me, Soph. It's been great.
Now, if you are someone who's listening who wants to explore further, you can connect with Claire and follow her work on LinkedIn, and I'll share all of her handles and links. If you're a clinician or someone living with POTS, the Australian POTS Foundation is a really great resource, and I would definitely recommend you check those out. They have their website, but are also on all of socials and LinkedIn as well. We've mentioned the recent state-of-the-art review a few times. So I'll definitely add the link to that in our show notes as well. If you're interested in a more comprehensive read, definitely recommend it if you've got the time. Really good. If you're going to read one paper on POTS, it would probably have taken the mantle for the one that I would recommend. And just to shout out as well, if you are in Australia this June, the Australian POTS Foundation is having their Converge conference on the 4th and 5th of June. I'm very excited about it. I've already registered and I'm dragging my husband, who's also a physio, along with me. That conference really is going to be just an opportunity to learn, connect and share knowledge. And what's really exciting is it's got sessions for clinicians, researchers and people living with POTS as well. So it's not just our professional communities, it's also for the broader community as well. So if you're interested and maybe have capacity to check that out, definitely head to the website, because there's lots of information about the conference there, and hopefully we'd love to see any listeners turning up there as well. So all of those links I'll chuck in the episode description. But thank you again everyone for listening, and thank you Claire for your time, and I hope to see you all next time.
Lovely. Thanks, Soph.
If you enjoyed this episode, we'd love for you to share it with a friend or a colleague, or maybe even leave us a quick review. Don't forget to subscribe so you don't miss any future episodes. If you've got an idea for a topic or a guest that you'd love to hear, definitely send us an email at podcast@vivepainfatigue.com.au. If you're interested in more resources or information, head to our website where you can find out more about our clinical services and our professional education. Until next time, take care.